All right, good morning and good afternoon, everyone. We're going to go ahead and get started. Thank you, everyone, for joining today's webinar, which is entitled COVID-19 Custom Planning Product Spotlight, Elective Surgeries, PPE, and Post-Acute Demand. My name is Greg Schneider, and I'm the Chief Marketing Officer of Cuventis, and I'll be moderating the webinar today. We have a lot of great and very timely content to cover today. But before we dive in, I wanted to just note a couple of things regarding logistics. First off, you can submit questions throughout the webinar by clicking on the Q&A button that's at the bottom of your screen. You can ask questions throughout the course of the presentation, and then we have some time allocated at the end of the session for answering those questions. And then secondly, everyone's favorite question, yes, we will be sharing slides from the webinar as well as a recording of the webinar after the event. So you can look forward to that. And with those housekeeping items covered, let's go ahead and move forward. Jeff, if you could advance the slide. Fantastic, thanks. It's now my pleasure to introduce our main speaker for today, Dr. Jeff Munzer. Jeff is the Vice President of Product at Cuventis, and in this role, he is responsible for product management, for product design, and for product analytics. Prior to Cuventis, Dr. Munzer led mobile product development and was the product team's chief of staff at Medallia, which is an enterprise cloud company that's focused on customer experience management. He holds a PhD in electrical engineering from Stanford, where his research focus was on performance optimization in queuing systems. And with that, I'm pleased to turn things over to you, Jeff, to begin the presentation.
Wonderful. Thank you so much, Greg. And good morning and good afternoon, everybody. Very nice to spend the next hour with you sharing some of the work that we've been doing on COVID-19 and beyond. As a quick preface, I'm going to go at a brisk pace today because there's a lot that we'd like to share with you all, and I'd like to save some time for questions at the end. So let's go ahead and dive right in. For those of you who are not familiar with us, Cuventis provides the first patient flow automation solution for healthcare. We use artificial intelligence and machine learning combined with behavioral science and data science, and we apply them to hospital operations to help improve efficiency and flow. We are a proven partner working with many health systems and hospitals across the country, over 120 successful deployments, and we consistently deliver transformative results, seeing up to 0.8 day reductions in inpatient length of stay and decreases in emergency department length of stay and improvements in operating room flow as well. Now, since this COVID-19 pandemic started, we've been partnering closely with our customers to help them prepare and manage the crisis. I'm sure we're all familiar now with curves that look like this and graphics that represent the flattening of the curve that's required. And there's been a lot of discussion about how we can use different techniques such as social distancing to flatten that curve. But the other side of the equation, as we all know, is that we need to do everything that we can as healthcare providers to create as much capacity as possible. And in this regard, we've been doing work all along with our partners, operational efficiency and patient flow, which is key to creating the virtual capacity that's needed to mitigate the pandemic and manage through crisis times like this without requiring additional staff or while placing the lowest possible burden on our overburdened staff. In many ways, we think of this like washing our hands. The efficient patient flow is something that we should always be doing, but it's important now more than it ever has been before. So as we have addressed this challenge with our partners, we have seen an evolution in this pandemic and an evolution in the way that we're all thinking about how to manage through it. And so in addition to the core patient flow automation solutions that we provide to help with that virtual capacity creation on an ongoing basis, represented here with this post-peak transformation arrow, we've developed a number of new solutions that can be immediately deployed to help plan for and manage through the earlier stages of this pandemic. So we'll today be taking a look at our COVID-19 planning solutions that we have been developing over the past few weeks. And we'll take a brief look at some of our COVID-19 capacity creation solutions as well. These are focused on helping with incident command centers and managing through this crisis for health systems and hospitals. So we will touch on all three, but the main focus today will be this COVID-19 planning bucket. All right. So with that, let's dive into the first thing we'll talk about, which is we're going to spend a couple minutes regrounding on our COVID-19 scenario planner. This is a product that we have made available pro bono. I know many of you on the call are using this in your health systems. This is a tool that very importantly is focused on hospital and health system localized planning, which is different than some of the state level and national level models that are out there. This is used to predict COVID-19 hospitalizations and census and different levels of care for your hospitals and health systems. There are a couple hundred hospitals and health systems around the country who are using it on a daily basis to help plan and evaluate different scenarios. This model is based off of an SEIR epidemiological model with curve fitting for the effects of social distancing. We found it to be accurate relative to other models and back testing. I'll mention that briefly in a couple minutes. And it's also kept up to date. So it's automatically updating assumptions from the latest local data in every region around the country. And then we also update the core model itself based on what we're seeing in the literature and what we're seeing around the world on a weekly basis. As we have been using this with our partners over the course of the last few weeks, we've seen very promising results in terms of how accurate it is for planning purposes. And here I'll just briefly mention that when compared with another widely used model, that model's forecasts from IHME for a day ahead have been shown to have on the order of 100 to 200% error, whereas our latest version of our model, our 7 day ahead predictions, when compared to those 1 day ahead predictions, are showing dramatically greater accuracy. So why don't we take actually a quick look now at that scenario planner just to reground everyone here and to highlight some of the newest features, and then we will build from that into our new COVID-19 planning tools. All right, so this is the localized COVID-19 model and scenario planner. I have here loaded up a hospital that's in our backyard over here in the Bay Area in California. This is actually the hospital where my daughter was born. And what you see is a few different important things. You see the census that's implied for Med-Surg for this hospital by the COVID-19 demand. You see ICU census as well, ventilators, and a number of other important things that you would want to monitor and plan for. And now there are also a number of controls that are available on the left-hand side, whether it's the core COVID-19 assumptions for how the disease is spreading, hospital assumptions, and market level assumptions. Most importantly, though, there's a number of scenarios and planning tools that help you evaluate what's likely to happen going forward. And at this point in the pandemic, actually, we're seeing a general decline across the country, thanks to, in large part, effective social distancing measures. But we're also seeing many states and a national level, the plans coming in place for reopening at just different levels of pre-COVID-19 social distancing. So what we've added here, I just wanted to share this briefly, are some advanced social distancing controls to help model what may happen as we relax that social distancing in terms of COVID-19 demand. So in this case, for example, in California, there's a chance that we will start to relax social distancing measures at the beginning of May. We can actually model what the likely post-round 1 growth rate will be at that time. We can also evaluate different scenarios further into the future. So for example, if we believe that at a certain point, it's going to be important to reinstate social distancing as census begins to grow again, thanks to the relaxation of social distancing, we can model that as well. And all of these scenarios are really important when it comes to scenario planning for different possible outcomes. If we look here at what that might do, you can see a couple little bumps here as we go through the summer. And then what we may see is a resurgence in the fall. Now, of course, it's very difficult to plan more than 3 to 6 weeks out. And so the key to all of this modeling is that it's dynamically updating every day. So it helps give you a running forecast of what's likely to happen in the future. Okay, so with that, let's actually go back to our presentation here. And one thing I'll quickly mention before I go into the new set of planning tools is we do have an integrated version of this COVID-19 scenario planner, which lets folks, if you'd like to automate the data inputs and be able to automate the outputs of this model into other tools you may be using or into other Qventus products, for example, our Mission Control Center, that's a possibility that we're happy to discuss with you, and feel free to reach out with us if you're interested in that. All right, let's go ahead and dig into the custom COVID-19 planning solutions that we have been developing over the past few weeks and are making available starting today. So using the localized scenario planner that we just went through as a foundation, we've been adding additional tools on top of it to address a set of key questions, and that will be the primary focus for this webinar. As we moved into April, the pandemic has continued to evolve. The operational questions to answer have also been evolving. And some of those key questions that we've been hearing from our partners and from around the country are questions like, when can we resume electives? When will we have enough PPE to equip our staff? And how can we efficiently discharge to post-acute care? And so for each of these, we have built planning products to help with the answers. So why don't we start with the elective surgery planner? Our elective surgery planner is helping to address a couple key challenges. And I think it's particularly timely this week as many of us are evaluating how to start adding back cases. Some of the key challenges here are, of course, as we all know, surgery delays can hurt patients. Many of the things that we are deferring today that are that may be called electives actually have real patient morbidity implications that make them more like surgeries that should be not considered electives, maybe almost emergent cases, rather than what you traditionally think of as an elective. Also, as our backlogs grow, the operational disruption that's implied for the rest of the year starts to become meaningful as well. How are we going to run our ORs? How are we going to staff so that we can work that backlog down? And it also leads to other operational challenges when it comes to revenue loss and furloughed staff. And the other part of this challenge is that many regions around the country already have and have had, or soon will have, capacity to do more cases really right away. But the question is, how do I know when it's safe to start and how many cases can I safely be adding back? So the solution that we're providing here is it provides the ability to forecast capacity for elective cases, accounting for evolution in COVID-19 demand under multiple scenarios, as we were just discussing. And it helps evaluate the impact of different scheduling and operational strategies that your team might put in place. Some of the key capabilities that are included in this tool are that it dynamically adapts over time based on our Qventus SCIR model. We have an algorithm to help determine the maximum number of cases possible given the strategy that you put in place, the risk tolerance that you have, and your available inpatient and OR capacity as binding constraints. And it also can be used to help estimate the PPE impact of your surgical caseload by using the outputs of this tool in the next tool that I'm going to show, which is our PPE Demand Planner. So with that, why don't we take a look at the elective surgery planner, flip back over here to our screen, and let's switch over to that. So I'm going to continue using El Camino Hospital as an example here, since it's the nearest hospital to my home. And what you see here are a few important things. Let's actually take a look first at the surgery planning summary, which is showing that over the next 14 days here, the selected strategy, which we'll talk about in a couple of minutes, for adding back electives will allow this hospital to meet 200% of the expected COVID-19 demand. That's because we have a strategy in place to have a buffer on that demand, while serving an additional 450 surgery patients who would have been kept waiting, and offsetting almost $10 million in lost or deferred, in this case, revenue. What we see here are a couple other important things. So this graph here shows the elective surgeries possible. This is really the summary. The fill strategy that we're using here is prioritizing cases that are more medically necessary. That's why you see a little bit lower on the outpatient surgeries, but that strategy can be adapted. So this is really showing what's the maximum number of ICU admission surgeries that I can do, so surgeries that admit to the ICU, and what is the maximum number of surgeries that admit to Med-Surg beds that I can do really starting today. And you can see that today, actually, there's a meaningful number of cases that could be going on just based on inpatient and OR capacity. A couple of the other graphs here that are really important. One shows the Med-Surg census that's implied by this strategy. So down here, you see the typical census in blue, adding to that the COVID-19 census, which is this gray region, and then an additional buffer. In this case, we're doing a 100% buffer, so just in case there's double the demand. And then beyond that is the elective surgery census that's implied by the strategy that we've put in place. You see a little bit of a weekend effect here, as you might expect with census. And then additionally, we see the ICU census. So here what we see is that at some point here when social distancing is relaxed, ICU tends to be the most constrained. And so at some point here in the end of May, it's probably going to be prudent to stop doing as many cases that require ICU beds. And you'll actually see that we can do this blue region here in this graph shows how many surgeries we feel comfortable admitting to ICU. You can see that that goes away in May under this scenario and returns again later in the summer. Now, again, we want to typically use this for projecting for about 4 weeks out, but it does give a directional sense of what might be possible on longer time horizons as well. This is a scenario that I think many of us are going to find ourselves in, where we have a short-term opportunity to start adding back cases now before a potential resurgence as social distancing gets relaxed. And then as we move through the next year, this is going to be a pattern that we're very likely to see of peaks and valleys as we resurge and reapply social distancing, and then surges end. And then we have windows before things pick back up again. And it's going to be critically important to see those opportunities coming and to flex our operating room use into those windows where we have these lulls in demand to optimally manage our backlog. All right, so that's a quick overview of the outputs. Let's take a quick look at some of the controls here that help evaluate different scenarios. We'll actually briefly open up the hospital and surgical capacity part of the control panel. And here you can input various assumptions around the number of operating rooms, how much they're operating, how much is currently being utilized for urgent and emergent cases, estimations of how long those cases are, and we can help with that, the length of stay of those patients in their different care settings. All of those can get input here and affect the way that the algorithm fills cases. And then we can also look, let's close that one up, we can also look at surgical strategies. So here we've chosen to have a 100% COVID-19 demand buffer. This can be modified. We also have additional buffers that we can put in place on capacity. So let's say, for example, that we never want to go above 90% ICU capacity as we fill elective surgeries. So we can reserve 10% just in case of emergency. We can also evaluate the effect of doing a similar capacity buffer on Med-Surg beds. Now, this actually helps evaluate other types of strategies. So for example, if we didn't want to use inpatient beds at all, we would take both of these to 100, and this actually would tell us how many outpatient surgeries we can fit in our ORs right now. Obviously, those have PPE implications and other supply implications, which we'll talk about a little bit later. Let's actually take these numbers back for the rest of the demonstration. And we can see our update button here, which helps us just reset this. The other set of strategies you may want to evaluate are how much should I be running my ORs on weekends? And so here, for example, we've created 80 hours of availability on Saturdays and 40 for Sundays. You can experiment with this. You can also experiment with different elective surgery start dates. So if we are still planning to not resume elective surgeries for some period of time, you can see what that does to the number of patients you can serve, the revenue implications, and also just how your census evolves by setting that restart date sometime in the future. Okay, so with that, I'm going to swing back to our presentation here. And we are going to go into our PPE demand planner. So of course, elective surgeries have an implication on PPE as well. So these are all interconnected. Our PPE demand planner is used to project PPE consumption and then identify shortages or times where you might have shortages and be able to strategize around that. It is tough in this environment to estimate PPE needs and to make data-driven conservation decisions. because the COVID-19 demand is nonlinear, so traditional burn rate oriented methods of evaluating how long you can have a certain supply on hand may not apply. Actually likely don't, as we go through these exponential upswings and then rapid decreases in COVID-19 demand. It helps also estimate, okay, when am I going to have shortages given potential disruptions in the supply chain, et cetera? How does my inventory affect my availability of PPE to run my hospital? The other part of this that's really challenging is the type of supply may imply a very different usage pattern. Some supplies are issued and used per shift by care providers. Some supplies depend on specific interactions. And so modeling all of that can get fairly complex. So the solution that we're providing here is an analytical tool that forecasts PPE usage based on the COVID-19 scenario planner and the scenarios that you have created there. As a start, it includes PPE like gloves, gowns, N95s, surgical masks, and face shields. It can also include other supplies as we add them over time. And some of the key capabilities that I want to highlight here are, one, it's actually looking at hospital-wide usage of PPE. In that sense, it's actually combining 3 different demand models for COVID-19 demand. Your inpatient demand, the demand implied in the ED, and by the way, in the ED setting, this is helping model policies. For example, policies like we're going to treat every patient that comes into the ED as COVID-19 positive when it comes to our PPE usage. And it's also incorporating the elective caseload and your OR demand as well. So it combines all 3 of these together into one analysis. It actually can model different types of PPE, as I was just mentioning earlier, whether it's shift-based utilization, interaction-based, and case-based. It brings all of those together. Case-based would be for surgery. How much PPE do we need per case? It lets folks evaluate different strategies for conservation of PPE, and we'll show some of those controls, including the ability to evaluate reprocessing. So for example, for reprocessing N95s, resupply, and other inventory controls as well. So with that as an introduction, let's go back into our tools here. And we will go into the PPE demand planner. Immediately, what you see here is how long the current set of supplies will last. This is all demo data, of course. And the binding constraint right now for this demo institution would be 14 days remaining of N95 masks. What you see here in this first graph below is the projected PPE stock, including resupplies that have been input, or those are factored in here. So you can see how actually this decreases here in a nonlinear way because demand is increasing in this part of the curve exponentially. And then you can see the effect of these boosts in supply as well. All of this can be downloaded and output into other analytical tools that you're using as well, using our export feature up above here. And then we can use these projections to look at every individual supply, whether it's N95s, masks, gloves, gowns, and face shields, and again, more can be added. And we can evaluate things like the predicted daily usage of those by area of the hospital, whether it's inpatient ED or perioperative. And you can see as this grows, obviously as the number of patients in the inpatient setting were to grow, you'd see a disproportionate increase in usage there, and the cumulative usage over time that's implied by this strategy. There are a set of controls up here on top that help input the current stock you have on hand, but also a number of more sophisticated controls. For example, the rate of N95 daily reprocessing and face shields as well. You can evaluate different staffing ratios as inputs into this model, ED visits per day, and OR cases that you're running. If you're not using our outputs from the elective surgery planner, you can actually just input the OR cases per day that you intend to run directly into this tool. And then there are also a couple of additional buffers possible here. Supply buffer for other staff, for techs, therapists, transport, et cetera, based on your typical usage patterns, and also additional buffers for being more or less conservative with the way that you're evaluating your PPE consumption. All right, so that's a quick overview of our PPE demand planner, and now let's head back over to our presentation. And let's go ahead now to our post-acute demand planner. So the third tool that we've developed is a tool that helps anticipate post-acute demand to help prevent capacity constraints both in the hospital and in post-acute demand settings, post-acute care settings. The challenge here is that there is very limited visibility into the post-acute care demand that will be required from the COVID-19 population that's currently in acute care settings. It's also very difficult to identify the capacity constraints that may be on the horizon downstream at SNFs, for example, and then start to plan for possible alternative sites of care, as we know many of you are working on, whether it's leveraging hotels in the region, et cetera. So the solution here that we have been building is the ability to predict the demand of discharges to post-acute care facilities for the COVID-19 population that's currently in hospitals, and then be able to project when capacity crunches will occur based on SNF capacity in your local region. So some of the key capabilities that we're providing, one is we have a model for post-acute care utilization for COVID-19 patients who went through critical or non-critical care in the hospital using clinical proxies. There isn't very much data yet on how many COVID-19 patients go to which critical care setting, which post-acute care setting. And so we have used ARDS as a proxy after consulting with clinical advisors from across our partners and internally at Juventus, and influenza for COVID-19 patients who did not go through critical care but went through the hospital. And then we've taken a sample of 20 million patients across the country to evaluate their discharge rates to these different arenas for post-acute care based on their demographics. So that's the second piece here, is that the local demographics are accounted for in these projections, especially age is, as we all know, very important in trying to evaluate how many of our patients are going to be going to different post-acute care settings. And then our data also includes the baseline capacities of SNFs in every geographic region. So all of that's factored into this single analysis. So let's go ahead and take a quick look at that one. And we will open it up here. And so this is the post-acute care planner. It actually shows how many discharges we can expect to post-acute care tomorrow from a given hospital or set of hospitals. And again, this is using our underlying SEIR demand model as an input. We actually have data that we've pulled from claims data around the country to estimate the payer mix of those discharges to post-acute care. And we also are showing the number of SNF beds that are likely remaining, the SNF capacity in the HRR as of today. A few graphs here help tell the story. One shows a baseline level of non-COVID discharges for the hospital. When integrated with our data, this can be more dynamic, or when integrated with, for our customers, this can be more dynamic. And the total discharges that are additionally implied by COVID-19. This graph breaks that down by the discharges to post-acute care. This is total discharges of all patients. This is discharges to post-acute care. And then we also further break that down by discharges to post-acute care setting. So whether it's home health, SNF, rehab, LTAC, all of these are accounted for in this analysis. And then we can additionally show the SNF demand, and we can break this out by different types of post-acute care. And the capacity we're also pulling in, again, from the local region. And so we can see when, roughly speaking, we would estimate that we're going to run out of SNF capacity in a given region. There are a number of controls up at the top here, as usual, which help evaluate different input parameters, whether it's SNF bed count, occupancy rate, payer mix. Again, we try to make all of our tools simple to consume in the way that the analysis is presented, but also sophisticated in the way that scenarios and different input assumptions can be modified to really get as tight a planning fit for your institution as possible. Okay. So with that, that's a quick summary of our three new planning tools that we are making available starting today. A quick word on how we are bringing these to the market. So our goal in all of the work we've been doing on COVID-19 planning has been to make this available to as broad a community as possible. We, as a result, made our localized scenario planner free for the public. For these additional new tools, for us to be able to continue being able to develop them, we're providing them at cost. So as we develop them, we're taking our costs and we're passing them through to new customers who may want to use them at the lowest sort of cost threshold that we can continue to provide them at. So each of these 3 tools for new customers would be at a $10,000 price point. And when we deliver them together, we actually are able to save some efficiencies on our side because we can bring in all the same data at the same time. And so as a bundle, all 3 of the tools are being offered an introductory pricing of $25K. For existing customers, all of these tools are provided for free, given all the work that we're already doing with them. For multi-hospital systems, it's an additional discussion, but it's significantly discounted again because of the efficiencies that we can get in delivering them to a single institution. So for access to these, please feel free to register for our beta program at qventus.com/COVID-planner-beta. You can also reach out to us directly, and we're happy to work through this with you and get you started on the beta available right away. All right, the next thing that I'd like to spend some time on is some of the short and long-term tools that we have around capacity creation. So we focused on planning so far, and now we'll talk about how to create virtual capacity. So we're going to focus here on 2 areas. One is COVID-19 capacity for incident command centers, and this is focused on our critical resource mission control and ICU and Med-Surg capacity creation. And then we'll also spend some time on the post-peak transformation. And this is really to help us manage through these initial peaks and then the resurgent peaks that are likely to happen over the next couple months, and then to manage for the long term here as we get into the summer and fall and winter with potential resurgence in a meaningful way with the combined flu and COVID-19 surge. So let's actually start with our critical resource mission control. Again, we can deploy these rapidly and have deployed them at a number of our customers. This is used to gain visibility into critical resources such as negative airflow rooms, ventilators, ICU beds, and to project forward what may happen to those resources as COVID-19 demand evolves. All of this is real time. It helps augment mission control centers. And we have a number of automated real-time nudges as well that help resolve capacity constraints and help load balance across the organization. So this is helping identify opportunities in real time. We, as I mentioned, have been able to deploy this at a number of our customers. Dr. Karen Baum at Fairview mentioned this about it, talking about how it's so important in a time of disaster to provide tools that help reduce the cognitive burden on teams and to really manage patient flow effectively. And so we are very thankful for that partnership and have been glad to see it be of service to so many institutions that we work with. Our ICU capacity creation tools, again, focus on incident command centers here, but also these can be more broadly deployed as part of our full length of stay transformation solutions. Are really important right now. ICU capacity is incredibly constrained, as we all know, and up to 1/3 of ICU patients can be ready to step down at least 8 to 12 hours prior to receiving their transfer orders, which means that a lot of capacity can be unutilized in ICUs. Furthermore, a centralized incident command has very little visibility typically into ICU capacity creation opportunities, and therefore it makes it difficult for them to help. So this part of our solution, it leverages machine learning to surface and prioritize step-down candidates. It captures 90% of early step-down candidates, and then it provides workflow capabilities to empower a centralized physician team or distributed teams to identify barriers for those patients and expedite transfers with various adjustable clinical parameters as well. And similarly, we have tools for Med-Surg capacity creation by optimizing discharge. So as we all know, Med-Surg capacity constraints can result in upstream backups throughout the hospital, can prevent patients from being able to be stepped down from the ICU. And so we want to make sure that we're flowing patients out of the hospital as efficiently as we can. Also, in many cases, we're trying to free up staff from Med-Surg beds to be able to support ICUs when surges hit. So traditional discharge processes will be tested and continue to be tested throughout this year. And a lot of this is focused on making sure that escalation pathways and command center teams can support frontline teams in managing all of this patient population and patient flow. So again, here we have machine learning driven orchestration of discharge planning from the incident command center, here focused on the entire hospital population. And we're surfacing and prioritizing discharge candidates automatically. We can actually do this with our machine learning algorithms up to 25% more accurately than traditional discharge planning using expected discharge dates. And we can identify discharge candidates by resource type. So for example, if there are patients on tele or patients using ventilators, and we're trying to evaluate where we can potentially discharge from to free up those resources, we can prioritize that way as well. And the last thing that I'll spend just a little bit of time on is a couple minutes on our post-peak transformation tools. So as we are all coming out of this initial surge, it is time to start thinking about how we're going to prepare our health system for the longer term implications of COVID-19. And there are three factors that we all should be paying attention to. One is we're all going to have meaningful elective surgery backlogs. So it's going to be important throughout the rest of the year to be working that backlog down. And that means that we have to create as much capacity as possible in our inpatient settings. Second is that COVID-19 demand is going to be going up and down depending on a number of different factors, but it's reasonable to expect that come winter, we could see a relatively meaningful resurgence. The CDC actually just came out and said that again yesterday. And third is flu season on top of that means that this winter is going to be a pretty critical time for us to be as efficient as we can be in terms of managing patient flow. So with an eye toward that, our core solutions as Qventus are focused on length of stay optimization to create capacity. And our solutions are focused on AI-driven discharge planning and barrier resolution to hardwire sustained length of stay reductions. So our artificial intelligence predicts discharge dates, dispositions, and barriers days in advance. This is helping with the planning process and then managing patients through that, through their stay by identifying barriers automatically and helping care teams resolve those through automated nudges, through ML prioritized ancillary lists, and many other tools that integrate into the way care teams work. And critically, on top of that, we have a set of tools for managing accountability and escalating in real time so that managers of frontline teams all the way up to hospital leadership has a robust statistically driven toolkit, including statistically driven triggers for process fidelity. For example, if a process is starting to slip, we can automatically identify that, surface it, and help our leaders of healthcare systems and hospitals to coach their teams, both with positive feedback. We can identify kudos and opportunities to praise teams, which is going to be even more important moving forward for our care teams than it has been in the past with how tired we're all going to be, but also help identify where there are coaching opportunities as well. And all of this is supported with best practice process change and an operationalization provided by the Qventus team. We have a lot of expertise on helping bring all of this to life in a sustainable way, leveraging our technology. We're very proud of the fact that all of our inpatient partners have achieved statistically significant length of stay reductions, and it's so important now more than ever to be focused on that. So I'll actually go ahead and end here with a few thoughts. One is, as we look forward, it's going to be so important to take care of our frontline teams and helping them manage patient flow, helping reduce their cognitive burden is going to be a critical set of capabilities that takes care of them. So that's one. Two is this is a time to maximize the value of our different investments in healthcare IT, whether it's the EMR or other IT systems, and be able to deploy quickly, which is another thing that we are very confident in. And then third is we have to take care of our patients. And right now, patient flow has never been more important to quality and patient experience than it is today, because it literally is saving lives every day when we can create the space in our ICUs and in our hospitals in order to take care of more patients. So with those closing thoughts, let's go ahead and move into Q&A. Thank you all for joining, and we're excited to answer any questions that you might have.
Fantastic. Thanks, Jeff. Really appreciate it. As Jeff mentioned, we're going to open things up for Q&A right now. As a reminder, if you have questions, you can ask them through the Q&A interface that's at the bottom of the screen. And it looks like we have a number that have come in throughout the course of the presentation. So let's go ahead with those. First question is, when do you think people can add back in elective surgeries?
Yeah, it's a great question. As we've looked at COVID-19 demand across the country and how it's been affected by social distancing, we have had the feeling that you probably could have been adding back elective surgeries already, a couple of weeks ago. And in some cases, maybe shouldn't have ever stopped doing electives, given the way that this has evolved. That said, we wanted to answer that question in a data-driven way and with a number of different scenarios factored in. So that's actually the key motivation for us developing our elective surgery planning tool. And so what it shows is for many hospitals around the country, the answer is today. If you haven't already started adding back electives, there are patients who need surgeries. And our recommendation in general would be, and this is in line with many guidelines that are coming out, to start with the patients who need it most, assuming you have the capacity to safely take care of them. But what we're finding is, as we are using this planning tool with hospitals around the country, most parts of the country can start adding back a meaningful number of cases right away.
Great, thanks. So next question is a little bit more detailed from a modeling perspective. It is, how do you predict the growth rate post round 1 and post round 2? Does the tool do that for you, or are there guidelines for those inputs based on population?
Yeah, that's a fantastic question. So the answer is the latter. There are guidelines that we have put together for how to do that based on the population, based on the social distancing practices that are in place. We also have data on mobility by region, and so we can map different growth rates to different levels of mobility on a close to real-time basis or close to daily basis. So that's an analysis that we are happy to support folks in. I don't think there's a way to know what the growth rate will be a priori, because it's impossible to predict exactly when states will open and how much social distancing will still be in place. So that's why we think it's so important to move toward, instead of just a forecasting set of tools, a scenario planning set of tools, where we can evaluate the effects of different scenarios and different strategies in order to get as comprehensive a picture as we can from a planning perspective. So hopefully that helps answer that question.
Great, thanks. So another question specific to a particular region, it is that Hawaii is one large HRR, and could we pull together a single model that's used sort of at the state level for the state of Hawaii?
Yes, I don't see any reason why not. That is something that I'm assuming someone from Hawaii is asking that question. Please feel free to reach out to us, and that's something that we'd be happy to support you in. We can do that analysis right out of the box in the tool, but we can also do some special things maybe that might be helpful. So please reach out.
Perfect. Another question is, how long does it take to implement these new tools? I think the new tools probably the planning tools as well as the capacity creation tools.
Sure. Let's actually go back here in the presentation a little bit so we can talk about them. So these COVID-19 planning tools, they don't require an implementation. They're available now, and you can start using them right away. So the answer to that is zero time, I guess. The COVID-19 capacity tools, those require some data feeds for us to be able to provide those mission control capabilities and those machine learning algorithms. Those can be deployed rapidly because they're designed for supporting incident command centers on the order of 7 to 21 days. So again, we're happy to work with you on that if you have more detailed questions on the implementation timeline and how we roll those out. But within a month, the command center tools can be fully deployed as well.
Fantastic. So just a reminder to folks, we have a couple of additional questions that we'll answer. If anyone else has questions, please, now would be the time to ask them, either via chat or the Q&A section. Next question is kind of a broader question, I guess. How does your model compare to other models?
Sure. I think there are probably a lot of ways to answer that question. Let me take a couple angles on it. So one is the model that we've built is an epidemiological model. It's an SEIR model, which is a relatively more sophisticated version of one of these models, especially with some of the additions that we've made to it over time. Other models, so for example, the IHME model is a statistical curve fitting based model. It doesn't depend on underlying epidemiological dynamics, which has some pros, but frankly, we believe many cons as well. Other models have different versions of epidemiological mechanics. Some, for example, like the PEN model that some folks are using is an SIR model, which is missing a little bit of complexity around the different compartments as patients move through different stages of the infection. But probably the most important thing when we think about our tool is that it's designed for hospitals and health systems. It's localized. So while there are state level forecasts and national level forecasts, what we've done is automated the input of all of this local data, updated dynamically to help get as tight a set of projections for every individual hospital in the country as possible. We've also brought in demographic data from each local region and can influence the demand predictions based on that demographic information. So much has been pulled together to help make this be a real planning tool for folks. And the last thing I'll say is it's really designed for scenario planning. So instead of just being raw forecasting, hopefully, as you've seen, we can evaluate the effects of lots of different strategies and really hopefully operationalize this information in a much more robust way than just a straight forecasting tool. So a lot of different capabilities and modeling assumptions that go underneath it. The other way that I can answer this question is based on accuracy. We showed a little bit earlier in this presentation some of the comparison with, for example, the widely used IHME model, where our model has proven to be really accurate and up to 10 times more accurate than that model, depending on the state across the country.
Great, thanks, Jeff. So we're on our last question now. So if folks have any remaining questions, now would be the time to ask them. The last question is, some states are looking to relax social distancing measures as early as this weekend. What does our model say about that?
Yeah, very good question. Actually, why don't we dip back into our tool and take a look. So actually, I have that modeled here for our local hospital because there's a chance that we, although it's looking more unlikely by the day, that we relax some social distancing here in California, actually this weekend, or I guess I know in about a week. And so when we model that here, let's actually zoom in a little bit. And again, we are using some data which we can help provide on what a likely growth rate will look like once we relax social distancing to a certain degree, what you see is what you'd expect, which is a gradual rise that starts to get steeper and steeper as we go through the month of May. So it is not unlikely that as we begin to relax social distancing, we start to see some sort of resurgence in different parts of the country. And a lot of this is because you're starting to reconnect networks of people. And as they start to mix again, and because of the high number of asymptomatic cases, we would expect that you're going to see some increase again in growth rates. And so it's going to be a very interesting time, I think, in the month of May to see how different parts of the country bounce back. And in some sense, it's almost like a randomized experiment because different states are either taking very aggressive approaches to reopening or conservative approaches. So we'll actually all learn a lot more as we see some of the states that are more on the more aggressive side reopen, and we'll be able to calibrate all of our modeling accordingly. But I think another really important point to make here is that, for example, here what you can see is it's going to take, even if we relax social distancing, because in some places the amount of new COVID-19 cases has gotten so low that there's going to be definitely a period of time before we start to see a surge again, because these exponential curves they start off slow, right? So I think it's really important to think about how do we start taking care of patients who don't have COVID-19 but need care, whether it's important elective cases, et cetera. How do we manage through this window of opportunity that we have to take care of as many patients as we can? Because under just about any scenario, you would expect to have this window here through the first part of the month of May, where it's possible to take care of patients that aren't COVID-19, even if it starts to surge again by the end of the month. From that point forward, I would say it's very hard to predict what's going to happen because it will depend a lot on how states choose to respond to that potential increase. My expectation would be that we'll see social distancing measures get reenacted for periods of time, sort of in an on and off style, or sort of as Gavin Newsom has said here in California, a dimmer switch, as people try to manage the dance around COVID-19 demand.
Perfect. Super helpful, Jeff. Thanks for that. One additional question has come in, which is about availability. So basically, who's using the tool now, or basically has this just become available, or what's the availability of these tools? And so maybe starting with the localized model, and then moving on to the customized planning models.
Absolutely. So this tool that we're looking at right now is available and has been available for, I think, over a month now. There are a couple hundred hospitals and health systems around the country who are using it. Some states, every health system in that state is using it, and they're using it in collaboration with each other. So this tool is again, publicly available, provided pro bono. And a large number of folks around the country are using it for their planning. The other three tools that we looked at today, so the elective surgery planner, the PPE demand planner, and our post-acute care planner, those are being released today. And so they're going into an open beta. That's a large part of the reason why we're having this webinar, is to announce these tools, showcase them, and share that they're ready to be used. So they are available starting today.
Fantastic. Thanks, Jeff. One other question came in, which we addressed
right.
at the top of the hour, which we'll recap, which is just will the slides be available? So the answer is yes. We'll make the slides available after the session today, as well as a recording of the session. With that, since there are no additional questions, we will go ahead and wrap for the webinar for the day. So on behalf of Jeff and the rest of the Qventus team, I'd like to thank you all once again for attending. This concludes today's webinar. Thanks, and have a great day.
Take care, everyone, and be safe.